Today, this 25 years old female patient presented with traumatic cataract that was 1 month old due to blunt trauma, and you can clearly see the posterior synex and irregularly oval pupil. As it was a traumatic case, so I performed B scan and retina was normal. So I proceeded with the surgery under local anesthesia. Now I am making the phaco main port with 2.75, and now I would like to stain the anterior capsule under the air bubble. Now with the Simcoe cannula remove the blue dye, and you can see that the anterior capsule is stained. And not only I am removing the dye, but also I separated the anterior capsule and broken the posterior synex. So I have taken advantage of the Simcoe cannula and swept under the iris inferiorly, and you can see that I have broken the posterior synex. Now I am making the side ports. I make two side ports with 15-degree phaco knife. With one side port I do the capsular access, and with the larger one I do fine irrigation aspiration. So now with the help of a cystotome I would like to perform the capsular access. Now it's a very important step because it's a traumatic case. The anterior capsule is fibrosed and wrinkled. Now that's the point where I have broken the posterior synex, but here the capsule is very resistant and it is not going forward. So that's why I started to the access from the other side. You can see. So you should know if there is a resistance from one side while performing rexes, you can start it from the other side and complete it. Now here still the rexes is a smaller and eccentric, so I have to enlarge it little bit. The AC became shallow, so I am putting viscoelastic, and now I would little bit large the anterior capsular axis because the center of the visual axis should be clear. So slowly, as it's a traumatic case, I don't want to damage the capsule further, so very slowly I am little bit enlarging it, and now the center is clear, but it's an incomplete rexus. The rexus is eccentric and inferiorly it is not complete because there is a patch of capsule which is very thick, and I will complete it with the help of Vanna scissor. But first I am removing the lens matter. You can see with the help of with the Simcoe cannula I have aspirated all the soft cataract and few remnants are there, and you can also see inferiorly at 5 o'clock position that there is that capsular piece which is not continuous. So now you can implant the IOL. First you will get the support of IOL, and then you can cut it with the help of a Vanna, or you can put viscoelastic, and before implanting the IOL, if the view is clear, you can cut that capsular tag. So I have removed all the cortical sheets. There is no PCR, and now after removing all the cortical sheets, then I'll put the viscoelastic and try to cut the inferior capsular tag that is present, because it can also, it is near the visual axis and it can obstruct the vision. So we need to cut it in such a way that the rexes didn't get radial. Under the capsular tag I am removing the material. Now I have put the viscoelastic, and now with the help of a vena, if you have got a micro scissor then that is better. So I am cutting that inferior anterior capsular tag with the help of a vena scissor. Even if you can't cut it clean, if you do multiple cuts in it, it will also not come forward in the visual axis and our goal will be achieved. Now I am putting viscoelastic, and now I will implant the foldable IOL in this patient. Very slowly and gently inject it. So half of the lens is in the bag, and now I'll put the remaining in the bag in this smaller capsular axis. With the help of a dialer. Now remove all the viscoelastic. You can see the visual axis is clear, the foldable IOL is in the bag. Now at the end, perform hydration of the main port as well as the side port. So I hope you have enjoyed this traumatic cataract surgery, and that was an interesting case, so I thought I should share with you. Thank you very much.